Hi, and welcome to blackdoctor.org. I'm your host tonight, Shamika Rhymes. March is National Colorectal Cancer Awareness Month, and we're here tonight to shed light on this important health topic to help you stay informed and proactive about your own health. Let us know where you're watching from in the chat. I do see some folks already popping in with Pittsburgh, LA, Asheville, Gastonia. Welcome, welcome. Don't hesitate to drop your questions in the chat for our experts tonight, and make sure that you share this with your network because you never know who needs it. So let me introduce you to tonight's panel because this conversation is going to be good. So I had to speed through this intro. So tonight we have Dr. Stephen Evans. He's an oncologist and patient advocate. He's joining us tonight. Hi, Dr. Evans.
Good evening.
We've got Dr. Maxine Owusu. She's an emergency room physician in Atlanta. Welcome.
Thank you for having me.
We've got Dr. Janice Fields. She's the gastroenterologist. Welcome, Dr. Fields.
Good evening.
And then we've got Arkell Cox. She's a patient advocate.
Good evening. Thanks for having us.
Thank you all for taking time out of your busy schedules to join us for such an important topic tonight. So I'm going to start with Dr. Janice Fields. What is colorectal cancer and where can it be found in the body?
Thank you. Thank you for having me. Colorectal cancer is a disease, a cancer that occurs in the large intestine of the body. The colon is what processes our waste and eliminates, how we eliminate waste from our bodies. Colon polyps are clumps of cells that are abnormal, that start benign, but if not removed, can progress to colon cancer. And this disease, unfortunately, is the top killer of African Americans and all Americans, actually, in this country.
Thank you. Dr. Owusu, what are the current statistics for colorectal cancer in the Black community, and how does that compare to other populations?
Yeah, so in the Black community, from the literature, it's saying that 20% of Black Americans are more likely to be diagnosed with colon cancer, and 40% are more likely to die from colorectal cancer compared to white Americans. So this is obviously a staggering, statistic, and it's several reasons why this can be the case that we can get into as well.
Okay. All right. And I forgot to mention to the panelists, like if you want to jump in, feel free. If you have, if you want to add on to a question, please feel free to tell me to wait a second before going to the next question. Dr. Evans, what are the current colorectal cancer screening guidelines, and are those recommendations tailored enough to address the earlier onset or higher risk in the Black community?
Well, thank you for that question, and thank you for having me. As a general surgeon and surgical oncologist, it's very important for me to increase awareness about colorectal cancer for our communities of color and what tests are best for our community. There are several tests. The gold standard, however, is called a colonoscopy, where you have a lighted tube that is used to investigate the entire lining of your colon to look for growths called polyps, which was mentioned by Dr. Fields, which can be precancerous. And that is the gold standard. Why is it the gold standard? It's because with this test, you can not only identify the growth, which may be abnormal, but also remove it at the same time and determine if it's cancer. And guess what? 90% of the time, even if it is a cancer, you cure it. So that's why colonoscopy is the gold standard. The other tests are stool tests, such sampling your stool for blood and or DNA, that can slough off of the tumor polyps that form in your colon, and also a scope called a flexible sigmoidoscope, or a CT colonography, which uses a CAT scan to help visualize the colon and its mucosal lining.
Okay, with the screenings, and I'm coming right back to you, Dr. Evan. When should someone start being screened? Because I know that for some people that have that it runs in their family, that particular type of cancer, and I'm not sure if the recommendation has changed, if they should start like as soon as possible with being screened.
Well, the National Colorectal Foundation recommends that 80% of people get screened. And the age recommendation just changed a few years ago to about 45 when it was formerly 50, because between the ages of 45 and 75, we're able to catch over 95% of the cancers. But my conversation and my attention to shine a light on for this conversation is the fact that the highest incidence of colorectal cancer is in the age from 20 to 45, 44. And so who's thinking about getting screening at that age, the 20s and the 30s and the 40-year-olds? And we need to have this conversation so they are armed with the tools to know why it's important, if they have a family history, if they have blood in the stool, or see changes in the characteristics of the stool, or if they have fatigue or weight loss, that they too can have a conversation with their care provider or physician to get screened. Because screening so far is the best test for early detection, treatment, and it does save lives.
Thank you. Thank you. Arkel, how do the different screening methods that Dr. Evans just talked about compare in effectiveness for early detection, especially in underserved communities?
Well, for me, I find in the last 13 years of being a patient advocate for colorectal cancer is primarily doctors, physicians, they would prefer you to have a colonoscopy. That's ideal. But in our communities, not everybody can walk in and say, I need to, speak about this and get a colonoscopy. So in that case, any means of, finding out what's going on. That's the Cologuards. This is the male test that you can get. They're not 100%, right? And so, but at least they're indicators. If you are actually having these issues where there's blood in the stool, weight loss, constipation, all the things that can happen to you with this cowardly cancer is what I call colon cancer, because it's very cowardly. It's in your colon and it does not affect you if you do not get it, diagnosed in time. And so for me, I would prefer you going in to see your physician, having the conversation candidly, and getting a colonoscopy. Now, if you can't do that, then there are the other options, which will also give you an indication. Is it as safe? I mean, as it is as foolproof? No, but at least it's an indicator that can get you in the right step. And what I found is when you're in the doctor, when you're at a physician, at a facility, having this procedure done, you're more likely to continue with the steps of treatment. If you're doing it at home, you oftentimes think I did something wrong, or you're not going to take the test because nobody's holding you accountable of going in and making sure that you are getting the treatment. So I would prefer that we all have the conversations with the physicians and get a colonoscopy. But if that is not the case, the secondary means are there for that reason as well.
Thank you. And Arkel, can you share your story and
We
how
got
you got involved as I'm jumping straight to it. Can you share your story?
Well, I have, and as you can see, I'm wearing the colors of colorectal cancer as my nails, and you'll see me for the entire month of March because I'm really dedicated to this. I am a widow. My husband passed away 13 years ago of stage 4 colorectal cancer. He was 40 years old. He died 2 days after his 40th birthday. He was 6'4", 240 pounds, just picture perfect. He didn't smoke. He drank casually. There's no family history. His mother and father are both in their 80s and healthy, right? And so my husband came down with this cowardly disease, and within 3 months, he was gone. We had the best care. We were in the best hospitals. We had patient advocates. We had private patient advocates, but it was just a very aggressive cancer. In it spread from the colon to the liver to the kidneys to his head, and within 3 months he was gone. And so for me, because my husband was so young and so promising and had so much life to live, and now that I've learned within the year after his death that no one has to die, as Dr. Evans said, 90% of the patients can be cured from this. And so my job, right, what I decided to do in these past 13 years, and until God has given me breath and taken it away from me, I will tell everyone to get a colonoscopy. You have to go get it done, to have the conversations when we are at the dinner table and somebody's squinting and they says, "What's wrong with you?" You say, "Oh, I don't know, I got a headache." They said, maybe you need to see the ophthalmologist. Maybe you need to get glasses. Why are we not saying, "Hey, Beb," to your spouse, to your mother, to your father, to your brother, to your best friend, "There was blood in my stool today. That's not regular." And then the conversation would be, maybe you should get checked out. But there's this whole stigma behind it. I spoke at a school today with elementary children, and the assistant principal is going in next week for a colonoscopy because I refused to leave until she called her doctor, because she's saying to me, "Oh, I know your story, but I got to get this thing and my pastor's praying for me." I said, "Well, your pastor may not, he may be doing something else for you in a minute if you don't go get this done." And it's the mindset, they don't want to take the prep. Things have changed. There's a pill now, right? You drink the drink that tastes like Sprite. Everything has changed. You're not sitting with a gallon of flux all day. And prevention is better than cure. Right? No one has to die. So that's my story. I do this because my husband was 40 and he didn't have to die. But there was no family history. There was no one telling us that this disease is plaguing our men and our women in their 20s, their 30s, and their 40s. This is no longer the old man disease. So we have to be very verbal and we have to be vigilant about this disease. So that's why I'm here.
Thank you for sharing, and I want to give you my condolences. Um, yeah, thank you for sharing that and being so open and transparent and being that patient advocate. And so allowing the audience and us to hear your story. Thank you for that. Before I move on, did anyone else want to weigh in on what Arkell just shared?
Yeah, I'd like to just add, thank you for sharing your story, Arkell. It's amazing, and thank you for what you do, because education is key, and people talking about those experiences. Who, for every patient that has an experience where they say the prep was terrible, there are 8 to 10 more who say it was fine. So having those conversations and encouraging our spouses, our peers, our coworkers to come in. I see a lot of patients who come in, especially the men. Their wives may not have been able to get them in, but a coworker tells them about their experience, or unfortunately has, experiences colon cancer or polyps, and that's what gets them in. So it's not, it's destigmatizing both the disease and as well as the preparation and the process, talking to your primary care physicians, coming in and seeing your gastroenterologist, and talking through the process if you have reservations about it. Certainly an ounce of prevention is a pound of cure in this instance. So I thank you for being out there and advocating for this disease. And I too am wearing my blue.
Yes.
Tomorrow's Wear Blue Day.
Yes.
As well for colorectal cancer. Yeah.
Yeah. Well,
And
Dr. Fields. Oh, I'm sorry. Go ahead.
I'm sorry, and thank you again, Arkell, for definitely sharing your story, and that's what we really need to emphasize here tonight. Here you have a robust 40-year-old African American man who just, with the vigilance of a loving wife, was still able to just ignore symptoms and perhaps that he just thought were inconsequential, and before presenting at a late stage. And so our goal in this space, in surgical oncology and general surgery, is really to have our community feel comfortable about normalizing these conversations around cancer, because we don't have to compare people to do better. And we can do better by advancing the importance of screening and early detection where things are treatable. As a surgeon, I can perform minimally invasive procedures using a laparoscope, robotic surgery to resect the portion of the colon with its draining blood supply and lymph nodes and reestablish continuity for your bowel so you can go on to have a normal life and go on to healthy living, making healthy choices by exercising and eating well and being an advocate afterwards. Yes, it's hard. Yes, it's immediately you're afraid, but you're empowered. You're in this space for a reason, and your story isn't over just because you're given the diagnosis of colon cancer.
Yeah. Dr. Wasu, did you want to say anything?
Yes, thank you so much, Arkel, for sharing, your story. And I think, especially as an ER physician, I see people from the end of either they may be coming in because they're having difficulty having bowel movements, or maybe they're having blood in their stool, and then unfortunately through imaging we're seeing a large mass, or we're seeing signs that it has spread already. And so I try to make it in my practice, actually, when I see patients even coming in with unrelated topics. And when I see their age, especially within our community, I'll bring it up. Like, hey, I see how maybe they're around, getting around 40. I'm like, have you thought about this? And if not, I'll bring up that conversation quickly, and then I'll just kind of encourage them, like, make sure you talk to your primary care doctor about that, or, just to encourage them, even though they're not even there for that type of complaint, because I feel like that's a way that I can speak to them quickly and encourage them, and hopefully they'll be able to follow up and get this screening done, and at least just have that conversation started.
Yeah,
Okay.
normalizing the conversation.
Mhm.
Yeah.
Mhm.
Well, Dr. Fields, I think this is a good time to describe exactly what happens during a colonoscopy, like that prep and the colonoscopy, and what the visit looks like. Because clearly, it sounds like that is what a lot of people are afraid of, that prep, and then what the actual procedure is, and then after they're kind of like, well, what happens after that? So, can you walk us through what this looks like?
Sure, sure. Yes, I think most people fear that preparation, the dreaded prep. So the process, in order for us to, to examine the large intestine and see these polyps, which can be very small, we use a scope that has a magnifier, and I can see lesions as small as 2 millimeters in size. And so, in order to do that, however, all of the stool, the feces, needs to be flushed out of the colon. And so the process usually involves a day or two of clear fluids, just clear liquids. So no solid food. And then we use a rapid purge laxative solution, softeners and purgatives go lightly, Miralax and process. And then there are some that, yes, can taste like flavored citrus flavors, Sprite like flavors. So we try to make it palatable. And there is a bowel preparation with pills as well. But basically to flush the colon. So that's the part that most people don't like. But again, an ounce of prevention, pound of cure. And then once you're at the facility, you do receive sedation. So you have an IV place. We go over your medical history, make sure there's no contraindications on that day, make sure you're healthy enough on that day and got through the prep all right. And then once you're in the procedure room with myself, and you're sedated, the scope's inserted inside the large intestine through the rectum. The colon is probably about 5 to 7 feet in length, and we will snake this colonoscope through the large intestine, looking at these nice clean walls inside and looking for these small clumps of cells that we call polyps. If we see them, then they are snipped off, sometimes with a little metal forceps, sometimes with a metal loop. And risks can include bleeding, side effects of the anesthesia. It's given intravenously. Anesthesia professionals sometimes are involved in that. It can be a twilight sleep to a slightly deeper sedation process. And the whole procedure usually takes an average of about 15 minutes. And recovery time can be up to about a half hour after that. And depending on if I remove polyps, what size they are, what shape they are, sometimes where they are. That might determine when someone needs to return for another colonoscopy. And current screening guidelines range from every 10 years for an average individual, someone who has no family history and and had presented with no symptoms at that time, to sometimes every year if you have strong family history of multiple polyps, conditions called familial adenomatous polyposis, or every 3 years. And if you have other underlying GI diseases such as ulcerative colitis or Crohn's disease, you also may have an increased risk of colon cancer. That's somewhat it in a nutshell. But I think, again, having those conversations and people talking about their experiences is important because people don't know what to expect.
Mhm.
Absolutely. I see in the comments, there's quite a few people that said they initially ignored their symptoms. There's one that said she ignored blood for months. There's another one that said they didn't have blood in the stool, but had stomach aches. So there's a lot of different experiences I see going on in the comments right now. Thank you all for sharing in the comments. So Dr. Evans, at what point would someone come see you? And what I know you mentioned a little bit about the types of surgery that you could do, but what would a visit with you look like?
Well, just as Dr. Fields said, after they have obtained and sampled the abnormal growth, and the pathologist have looked at it under the microscope and confirmed that it is a cancer, I sit down with the patient and review not only the pathology report, but usually they would have come to me with other studies to stage them, such as a CT scan of the abdomen and pelvis, CT scan of the chest. And why is that? That's because colon cancer can spread to the liver and to the lung and to the brain, unfortunately. And in those instances, the surgery takes a back seat, and other specialists are called in, such as the oncologist, to discuss chemotherapy. And so if a person comes in at an earlier stage where they may just have even not cancer, but some may even have what we call high-grade dysplasia, where there are abnormal cells, but they have not penetrated through the bowel wall, we still would recommend doing surgery at that time. And as Dr. Fields said, the colon can be divided into 4 parts: ascending, transverse, descending, and sigmoid rectum. And each of them have a feeding blood supply. And so I go over them with a pictorial pamphlet that describes the anatomy and describes what section and portion of the colon will be removed and how we would aim to put it back together. And if they have multiple tumors and it's not possible to just remove a part of the colon, sometimes we do have to remove the entire colon. And in that instance, give what we call a low connection to the anus, where yes, they would have more frequent stools, and sometimes we'll have to give what we call a colostomy. So these are the conversations that I have and share with them, that after the specimen is removed, more importantly, we're looking whether or not the cancer, whether there is a cancer, first of all, confirmed by pathology, and that whether there are lymph nodes involved. And if lymph nodes are involved, like I said, they go to a oncologist who would recommend chemotherapy to improve their outcomes.
Okay. Thank you so much. Thank you both for those great explanations. Dr. Owusu, what are some key barriers preventing regular screening and testing for colorectal cancer among Black populations, such as the cost, insurance coverage, or even geographic access?
Yes, so that's a great question. And I think a lot of these disparities is what's kind of causing such a great divide when it comes to the statistics. So unfortunately, lack of access to affordable health care, and because of that, then that leads to delayed diagnosis, delayed treatment, and things of that nature. Of course, there's also a mistrust when it comes to the healthcare system. So that may be also a reason why there might be such a staggering statistic with how much within the Black American community, there's so many of us that may be having a higher percentage being diagnosed with colon cancer than others. Um, I would also say and in the literature where I saw that there were actually fewer referrals for colonoscopies among Black patients. And there's also a lot of bias when it comes to patient and doctor care. And so some of these things are unfortunately delaying patients from getting the right care in a timely manner. And that's things that we need to talk about and address when it comes to figuring out how we can get better care for Black patients.
Absolutely. I will add to that
Absolutely.
that that's
Um,
why I feel. I'm sorry, Shamika. I was just saying that you're 100% correct, but I feel like it's everybody's job, right, to spread this message because
Mm-hmm.
it goes back to the fact that nobody has to die from this disease.
Mm-hmm.
And so if we
mhm,
start making this conversation normal and we start making our, younger generations aware of how simple it can be to take the prep, how simple it is to have the procedure done.
mhm,
I tell people all the time, it is the best 10 to 15 minutes sleep you are going to get. You're going to
Mm-hmm.
be up and down. And I personally had a colonoscopy that wasn't warranted when I was 41 because my husband passed. I was a year older than him, but I couldn't talk to you about a colonoscopy if I didn't know what the process was. And as physicians, I feel that it's really important for you as well to really advocate for the patient, right? Really follow up with them. That is another really important part. As physicians, you guys are so busy and they give you such little time with your patients, but there has to be a way to follow up with them because when somebody walks out of your office, if there is just fell on deaf ears and they're not going to follow up. Also, I think it's important that we figure out within our communities, within our churches, within our schools, within our public forums, how do we educate someone about getting a colonoscopy, because if you find out that you have blood in your stool and there's a family history in the Caribbean. I'm from the West Indies. You really don't talk about what auntie and uncle and your grandparents have passed away from, right? You
mhm,
sometimes you don't even know what it is. So it's important for us to know the family history as well, so you'll
mhm,
know
Mm-hmm.
at what age is it appropriate for you to go and get that screening so you can be in preventive care. Then there's also, what is the verbiage that you can use when you go to the doctor and your
mhm,
doctor's saying, oh, the insurance is not going to pay for it? That is what I also advocate for. I will give you the verbiage to go into the doctor and they can't turn you away. They have to give you that colonoscopy. So all these
mhm,
things become part of the everyday mission, is what I call it.
mhm.
Yeah.
Can you give us an example of that verbiage as to what someone could say when they go to the doctor, Arkell?
Well, just being candid, there's blood in my stool. That is not normal. Most times when
Mhm,
someone goes to the doctor and they says there's blood in my stool, the physician, more times, this is all based on, there's nobody on the call. This is just based upon, thousands of people that I've spoken to in the past 13 years. They'll just say you need more fiber, right? You need to take maybe Colace or something like that. They're not giving them the attention that they need. And then two, you don't want to talk about it because especially if it's a man, because the first thing they're thinking is, I don't want anybody going up in my behind. It's nothing
mhm,
like that. It's a small
mhm,
scope. Are there dangers? Absolutely. They can be punctured, just like there's a danger walking out your house and going into your car. It's the same
mhm,
thing. Right. And so we just have to normalize the conversation, and you have to be candid. When you go into that doctor's office and you're speaking to them, be candid. That is the person that you have to be 100% transparent with if you're going to get the cure that you need. You tell them there's blood in your stool. I'm straining. I'm losing weight and I don't know why. These things, or all three things coupled together, that is not normal. And if the physician doesn't want to listen to you, then find somebody else and
Yeah.
report them because they're not doing their job and your life
mhm.
is at risk.
Yeah.
Yes.
One thing I would like to add, yes, I always recommend, if you feel like you're having a conversation and you feel like you're not being heard or listened to,
Mhm,
find a second opinion, so you don't have to be in a situation where you feel like you're not being listened to, go see another physician and so that's what I also recommend with patients, always pursuing that. Like, just don't leave it and just say, okay, fine, you know your body. So if you're seeing blood in stools, you're losing your weight and something isn't right and you're making these, you're letting them know and then they're not doing anything about it, go see somebody else.
Mhm. That's a great point.
And I like to add to that as well, because I think we're talking about screening, of course. So screening exams or patients that aren't having any of these issues, but we're seeing higher rises in the numbers of colorectal cancer in younger populations, and some of these people are having symptoms. So when you're having symptoms, it's a definitely a different conversation that you're having with your primary care physician. So we don't see numbers as high as we would like for regular screening, but we're also not seeing referrals as frequently as we perhaps should for our younger patients. Arkell, your husband, and the actor Chadwick Boseman, they were both below the screening age, and so there's no number yet that we know that would be right for some of those patients, but for screening. But if you're having symptoms, and I don't refuse offering colonoscopy to anyone who presents to me with any symptoms, any blood in the stool, some abdominal pains, weight loss, and sometimes the colonoscopy, if it's blood in the stool, the colonoscopy is higher on the list. But if they're having other symptoms that may be more subtle, we may try for a very short time other treatments, and then a colonoscopy would be appropriate in those circumstances. So I think keeping the lines of communication open, and yes, your body. If something's not right, it's not right to say to a patient, you're just to dismiss their problem, to endorse their complaint. And I'd rather do a colonoscopy and have it be normal, be negative, than to not do it and miss someone having, a serious condition.
Yeah, I see a comment this caught my attention as you were talking. Amber Mike, she mentioned earlier that she has she's a stage 3 survivor, but she said she was diagnosed younger than the recommended age, as a lot of doctors wouldn't take her as a patient or give her a colonoscopy. And she was bleeding at least 6 months, and it took 2 to 3 months to find someone that would even give her a colonoscopy. How normal is that? And anybody can answer that question.
I don't have numbers. Unfortunately, I do think it's happening more, way too frequently, as I said, it's a lot of primary care physicians have a lot on their plate. And I see patients who often present and say they were never referred even for a screening and they weren't having symptoms. And unfortunately, sometimes even when there are symptoms in a younger patient, like even blood in the stool, those can be dismissed. And I think they need to be taken seriously until you can fully be confident that, you're not dealing with someone with colon cancer.
Absolutely. So I was just about to ask you what responsibilities primary care providers have in recommending those screenings, and how can they better communicate the importance of testing to patients at higher risk?
So I can answer that. So continuing education and campaigns like this that, where we get the word out so patients can remember, we'll ask their primary care physician, what other screening tests do I need? Do I, they're checking off, do I need my mammogram and getting my cholesterol checked? I need my EKG. So colonoscopy or colon cancer screening should be on there. The Medicare, Medicaid services do educate patients. The VA system educates patients. Certainly advocates like Arkell, we work hard to educate patients in knowing about these things.
Okay. I think to that point also, Shamika, that I think it could be more awareness, just awareness. And we know the pink ribbon is all over everywhere for breast cancer awareness in October. And that is amazing that they have that recognition. But the month of March, then you should have in the office, you should definitely have the literature out. I have literature being delivered to 3 branches of my churches, at a hospital tomorrow for a symposium. So that should be the awareness. Like everybody knows, like, oh, she and her blue. Oh, there she go with her blue nails. That's right. Because now tomorrow, if you're not wearing blue, I'm not even answering the phone for you. I want to see you in blue tomorrow. And when somebody says to you, oh, it's a pretty color on you. It's not a pretty color. It's for a reason. And this is what it is. And it's the smallest little thing that can make the biggest impact. If you walk into your physician's office and this is March and you have, ask me about colon cancer. Nobody has to give you that information. You could print it out on your printer and you put it right on the wall. What does colon cancer mean to you? Was anyone affected with colon cancer? And now the conversation starts. Because now when I come into Dr. Field's office and I sit there and I said, well, what's this colon cancer thing you guys are talking about? Now a whole conversation that we would have never had before, but it piques my interest. Why are you so concerned about colon cancer? Or if you have in your office just the literature and you have it in, French and Spanish and English, and you're saying, you know what, take one of those pamphlets on your way out because you are on a time limit, and we get that. So if you say, take that pamphlet, and go home and talk to your family about it, you just made somebody aware of something that they didn't even come in for. And now that's how the little things start, just bringing our attention to it.
Yeah.
And my recommendation, just as Arkell had mentioned, she's bringing pamphlets and information to where the people are. We have to come outside of our offices and we have to go into the communities to affect change in the most vulnerable communities where it's needed most. We can no longer just sit and advocate from our ivory towers. We have to be in the churches talking about the importance of screening and early detection. We have to go to the barber shops and have our stylists feel comfortable, hairstylists or nail salon persons feel comfortable having these conversations. The Professional Athletic Association, we go pink in October. We need to go blue in March. This heightened awareness in the spaces where our culture often find ourselves, the music industry, every place has an opportunity to shine a light on this conversation to make it normal so that everyone feels comfortable and it eliminates the fear and the anxiety around being told you have cancer. So and what if you are told you have cancer at age 25? If you've heard these conversations in places that are familiar in your home, your cookouts, your Thanksgiving, then you won't be as afraid and you go forward with getting your screening. And if you're given a diagnosis, you'll find the faith and courage to go through and embrace the treatment recommendation. And for Black men, especially, studies have shown that Black men respond and really adopt the recommendations made by Black physicians, male physicians specifically. But unfortunately, there aren't enough of us. So that's why it takes a community, all of us, each one of us in our individual spaces to sound the alarm, elevate our voices so that we can live our best lives and not be afraid of having the word cancer at all.
I want to add one thing to that, to Dr. Evans, to piggyback off of what you just said. I know for the past 13 years that I get more of a response, a more positive response going back into the communities and talking to those communities because I look like them, right? I have a story that they can relate to. So they're going to trust me, right? So that's the bigger responsibility too, to speaking to our people because they trust us, right? And if they go into a physician's office and, there's nothing in common, then it's really, the trust is already kind of like, oh, do I want to do this? And then they may avoid it and we never see them again. But it is your responsibility as physicians of color to make sure that our communities, when you go to church on Sunday, if you guys want me to send you literature from the American Colon Cancer Conference, I will send it. I would send it. Let's start there. Like Dr. Evans said, when you're in the beauty salon, you're getting your nails done for an hour. It's our time. That's when we decompress, but at the same time, give back. Because I give back in the supermarket. I'm talking about it to everyone because nobody has to be robbed of their life and their dreams and their legacies to this cowardly disease. So that's how we spread awareness.
And when we do that, when we speak to one person, they speak to another person, they speak to another person, it is multiplied.
Yeah.
I agree.
Mhm. Yeah, so I wanted to also address for those 20 somethings that are probably thinking, oh, it can't happen to me. It'll, or not even thinking about a colonoscopy. What kind of advice do you have for them as to maybe how they should be, um, maybe prevention, or what should they be following specific diet, or maybe not necessarily diet, but eating specific foods, making sure they work out? Like, what should they be doing? What advice do you have for the younger folks that are watching? I'm going to start with you, Dr. Evans, since you and I were talking about it earlier.
Yeah, diet is very important. Colorectal cancer
Mhm.
is known to it can be prevented through exercise, maintaining a healthy weight. We really know, unfortunately, that being overweight and obesity really causes increased inflammation, and inflammation makes one prone to cancer. And just as Dr. Fields had mentioned, with ulcerative colitis and Crohn's disease, those are inflammatory diseases. But obesity alone, especially central obesity, is associated with increased risk of all cancers, uncontrolled diabetes. I have to have conversations about risk, postoperative risk of poor wound healing with increased weight. Your nutrition plays a vital role in your postoperative healing. So it is important for us to make sure that we're eating the right sources to consume our vitamins, vitamin C's, the antioxidants and fruits and vegetables. So all of these daily activities and lifestyle issues are relevant and for that 20 and 30 something year old as their space to be empowered and prevent cancer.
Okay, thank you.
And I will add to that.
Mhm.
I recommend when people ask me about diet, I certainly speak to the 20 and 30 somethings, and my older patients, I tell them, to tell their children and even their grandchildren, because what we eat in childhood may have an effect as well. We know cancers come from genetic mutations, and since we have two sets of DNA,
Mhm.
when there's a spontaneous mutation at a young age, and then you have a second mutation later on, then you can develop cancer. So I speak to them like that. So sometimes this you can set, have a better basis, even starting with in childhood, of having healthy grains, fewer animal fats, regular exercise, and as Dr. Evans, pointed out, keeping blood sugars controlled, and maintaining healthy weight. So there's a lot that nutrition and diet and lifestyle overall roles that those elements can play in our cancer risk.
Mhm.
Yeah.
Yeah.
I totally agree with everything that was said. And, I remember like when I was in my 20s, I felt like I could just eat whatever, right? And it's like, that's most of us, we feel like we can do whatever we want. We're young, but the fact is, yeah, a lot of the things that we eat will affect us later on. So we have to be mindful of that, and of course, not, you don't have to be extreme and become vegan, but just making sure that you're limiting red meat and unhealthy high fat diets and limiting alcohol, of course, and we got to make sure we're not smoking. So some of these things that we have to do and change. And I feel like once you start younger, it just becomes easier. It becomes more of a lifestyle change, instead of like a diet, and it'll help us in the long term.
Absolutely. Arkel, I wanted to go back to you. You shared your experience earlier, and you were essentially a caregiver. I'm just assuming that during those 3 months with your husband. Can you talk about how this disease can affect even the caregivers, and give some advice to those in the comments or the audience that's watching, what they could do to support caregivers, or what they need to do as the caregiver?
That is so amazing that you've asked that question, because I now have incorporated that in my talks, right? And so as a caregiver, there was nothing that mattered, right? It was in my life, it's God, my husband, my children, my family, right? Everything else follows. And so I obviously had my faith, but then it was my husband. I lived in New York Presbyterian Hospital for 3 months when he was in the intensive care unit where there was 6 beds on this side, 6 beds on this side, and the nursing station in the middle. I stayed there with him 24/7, 7 days a week. I lived in the hospital. I was taking a not even a, what do you want to call it, a wash up in the visiting bathroom, right? And I was able to figure out the schedule. I knew they clean it at 5. So at 5:10, when she was done cleaning the bathroom, I was in there washing up. So as a caregiver, I was taking care of who needed my help, my husband. I took that vow for better, for worse. It could be your mother, it could be your father, it could be your spouse, but you lose yourself. Right? You lose yourself because the goal is tunnel vision. You're thinking, I have to do everything in my power to make sure that they're okay. They're getting the care, they're getting the medicine. My husband got a haircut twice a week in the hospital. He had his manicure done, he had a haircut. I wanted things to be normal, but with doing that, I didn't eat, I didn't sleep. I didn't realize that I was looking like I needed medical attention, right? And so the caregiver cannot lose themselves. They cannot forget to take care of themselves, because if you are not well, how can you give care to someone that you love? The other important aspect of that is those people around you. Be mindful of the caregiver. Remember to ask them, how are you today? Did you eat? What can I do to help you? Would you like me to do the grocery shopping? Can I host dinner for you? Can I pick the children up? Can I run an errand? Can I just sit with you? What do you need? And those are the things that the caregiver needs. They just need to have someone be there to support them. And even if the person that they're caring for does not pass on and they're still here, there's still trauma. There's still trauma. So I think that every caregiver, whether it's stage 1, stage 4, whatever the outcome is, you need to also at some point, shortly thereafter, give yourself the best care. Speak to someone, because we're not God. We're not equipped to deal with this type of trauma, with taking care of someone that we love and knowing that we can't do anything but be there for them. So caregivers need to be cared for, and you can do that by supporting them and just sitting with them one day, and or remember as the caregiver to take care of yourself.
Thank you.
Raquel, thank you so much for that. A lot of people look and think of caregivers as the wife only, but I too was a caregiver for my wife when she was diagnosed with colon cancer. So our role as caregivers is to really follow the instructions of the person who is going through the journey, partnering with them. My wife kicked me out of the house. She said, go to work. I don't want you to see looking at me 24/7. So you have to follow their lead. And she says, when I want you here, I'll tell you to be here. And so that's the way it worked. And so my role was to listen and to hear what needs were being expressed by her, to accompany her with chemotherapy as that time went on, and to continue to hold her hand and sing to her, or what, pray with her, or whatever. And she requested, and that gave such a peace. And I was able to continue to do my work as a surgeon, and even share my personal experience with my wife having colon cancer with my patients. And I took pride in that, being able to be transparent in that space. I think it's important for us as providers and physicians to allow our patients to realize that we too are human, and we come into our space of being the professional in the room with our own family and even lived experiences that impact our lives as well. But through all of that, we still have to love ourselves first so that we can provide the best care and show up fully to our patients. and because that's what we're called to do. So we just have to be mindful, and thank God we have a village. Thank God we're not alone in this journey. As Arkell, I'm sure, had extended family support through her sisters and her church members, and that's what gets us through each day, knowing that we're not alone and in this journey. And that's an important message to share also for any age group.
Mm.
Yeah. Thank you, Dr. Evans. Thank you for sharing that. Well, this has been such a great conversation. I don't want it to end. I wanted to keep talking about this because it's so important. But as we wrap up, I wanted to get each of your thoughts. What do you want the audience to take away from this entire conversation? What's one, and I have a feeling I know what it is, but we'll go through it anyway. What one message do you want them to take away from this conversation tonight? I'm going to start with you, Dr. Evans. I'm just going to go around the room.
Yes. Well, the one takeaway from me is a quote from Dr. Margaret Mead, who says, "Never doubt that a small, thoughtful, committed group of individuals can change the world. Indeed, it's the only thing that ever has." And so I want all of you in this listening audience to realize that each of you have a voice. And we hope that this time with us this evening has given you the tools to shape the conversation around the importance of screening and early detection, because screening and early detection does indeed save lives. And that's my message. Spread the word.
Thank you. Love the quote. Thank you.
Yes.
Dr. Owusu, how about you?
So for me, this conversation was great, and I hope it was very beneficial to everybody else listening. And what I would want other people to get from this is advocate for yourself. Don't let anyone tell you no. And so if someone says no and you're having symptoms and you know something isn't right, go find another doctor. So that's the thing. We have to advocate for ourselves. Yes.
Yes, that's important.
Mhm.
Dr. Fields.
Wow, I love these messages. This has been an amazing evening. Thank you so much for having me. And what I would like to leave the audience with is that you are not alone in this process. That advocating for yourself, getting information where from where you can from trusted sources. Just know that that your providers, um, if you don't find the right one, go to the next one, to get what you need. And this journey, there are multiple resources. This is an amazing platform to get to get information. But the American College of Gastroenterology is another, and the Colorectal Cancer Alliance is another amazing resource for tips. And I hope we are able to share them beyond this forum here today. But if if there are further questions, certainly reach out. And I just want to share that that this information you can advocate for yourself, but you can also, like I said, educate your neighbor or your church member or your friend, to encourage them to have to undergo screening, because screening does save lives.
Thank you. And thank you for sharing those websites as well. Arkell, how about you?
I just want everyone to be the change that they want to see. I want us all community to tell someone, just don't say I was on a Facebook Live. Tell them why you were on this Facebook Live. I challenge everyone on this call in the comments, whether you're listening on the way home, wherever you are, to talk to everyone that you know. Tell them, hey, you ever thought about getting a colonoscopy? Have you had a colonoscopy? Let's continue the conversations outside of this. Let's normalize the conversations. I would charge everyone who is listening or will listen to this or is just on this forum to go out. Even us, when I leave here tonight, I'm going out. I'm going to tell them, I'm going to always say, I would love us to see the month of March for their blue ribbons everywhere, that everyone is talking about colonoscopies. I want us to go ahead and dispel the myths about having the prep, how it used to be to what it is now. And I want us to know that it's the best 10 to 15 minutes of sleep that you're going to get, and you're going to live your life, because no one has to die from this cowardly disease. And it's important for us to make that known to everyone. And I think together we can do it. And I'm grateful for this platform and for everyone on it. And just let's create the change that we want to be.
Absolutely. Thank you. Thank you. I want to thank all of you for coming and sharing such amazing insight. I know that I've been looking at the comments. I think everything you all have said tonight is definitely resonating. I see a lot of thank yous for this conversation, because it did need to happen. And everyone, for more information on colon cancer, colorectal health, head over to blackdoctor.org for more articles and resources. And of course, check out the websites that Dr. Fields mentioned as well. And I hope you all have a great night. And thank you again for joining us.
Thank you.
Thank you.
You.